Welcome to all the trainees who have joined us in this YouTube platform to discuss various exam related topics. Today we are going to discuss renal lesions. Thank you for the trainee who has agreed to record this session. So it will be a excellent revision tool for the other trainees preparing for the FRCS urology exam. We will jump into the situation. You are in a clinic and your GP has referred a 40-year-old healthy male because his ultrasound done to evaluate right-sided loin pain has shown a possible lesion measuring 2.2 centimeter in right kidney midpole. How will you evaluate him?
So I see him in a 2-week wait clinic. So I'd want to, in my history, first elucidate a few points. I want to know how long he's been having loin pain for, if it's on the same side. He's been having any visible hematuria, any systemic symptoms like any weight loss or chest symptoms or leg swelling. I'd want to get a general idea about his performance status and comorbid status, particularly anything that might affect renal function or cause CKD in the future. I want to know about any previous urological history, particularly any operations on his kidneys or any general abdominal operations. And of course, I'd ask about any risk factors for renal cell cancer, particularly family history and hypertension. I then go on to examine him. So really, I'm just having a general look for any signs of cachexia, examining his abdomen for scars from previous surgery. I could palpate his kidney, see if I can palpate a mass, but I probably wouldn't be able to in this situation. And then I'd normally generally have a look for any leg swelling or any signs of a varicocele. Again, probably not relevant in such a small renal mass. I would then counsel them on further investigation. So I would generally measure a renal function at this stage. And I'd also do a full blood count, LFTs, and a bone profile. And I'd then talk to them about further imaging in the form of a renal protocol, CT, and CT chest.
What is the importance of LFT?
So generally with renal cell carcinoma, I'm looking for paraneoplastic syndrome. So Stauffer syndrome can cause deranged LFTs. That's the reason I'm doing it.
So what is Stauffer syndrome?
So it's a immunological syndrome mediated by cytokines. So I think IL-6 and IL-8 are the main ones, which can cause deranged LFTs as well as systemic symptoms like fever, and tends to resolve once the tumor has been removed.
What are the other paraneoplastic syndrome components for renal cancers?
The most common one is hypercalcemia. So that can be mediated by parathyroid-like hormone. Obviously, it can also be from bony metastatic disease. Hypertension, they can get polycythemia, and rarer things could be other hormone-mediated syndromes related to insulin, like hypoglycemia or hypogonadism.
Yeah. Glad that you mentioned it's a parathyroid-like hormone. It is not the parathyroid hormone. So the renal lesion can produce hormones which are parathormone-like hormones. And other thing which you can include is fever. Fever itself is a paraneoplastic syndrome.
Okay.
What are the triad which usually historically described with renal cancers?
Classically, it's hematuria, loin pain, and a palpable mass.
Okay. How far it's relevant in this day and age?
Not very relevant. About half of renal cancers now are picked up incidentally on imaging.
Okay. So our gentleman, all the blood investigations were normal. Examination is normal, non-contributory. His performance status is 0. Is not on any medications for any medical illness. How are you going to evaluate him further?
So yeah, as I say, I need to get further imaging in the form of a renal protocol, CT, and a CT chest.
Okay. So why do you want to do CT chest straight away?
I suppose there is an argument for waiting, but I think practically speaking, it's difficult to get CTs done. So I'd rather have all my staging investigations done in one go if possible, presuming that this turns out to be a renal mass, which may be malignant.
Yeah, so it could be argued in both ways. Say, for example, if your renal CT scan showed only non-malignant components like maybe like a Bosniak 2F cyst or any other hyper intense cyst but not malignant, then the CT chest will be a overkill. But having said that, if you discuss from the point of the MDT patient breaching the treatment pathway, etc., there is a role for CT thorax in the starting itself. But in general, the staging CT thorax comes only if you have proven that this is RCC. Okay.
Okay.
Okay. So, what is the difference in the CT you mentioned? What is the protocol for this renal specific CT scans?
So, I mean, the protocols can vary between organizations, but generally speaking, it's a multi-phase scan. You need, at the very minimum, a non-contrast phase and a nephrographic phase at about 70 to 90 seconds post-contrast. And that's going to give you enhancement of any lesions within the renal parenchyma. You may also include a CT urogram to assess its relationship to the collecting system. You may even have a corticomedullary phase, which is about 60 seconds, and that can give you some more idea about vascular anatomy.
Okay. And your prime aim is to characterize the tumor. How will you characterize the tumor based on CT scan? What findings you will look for?
Primarily, I'm looking for enhancement, so more than 15 Hounsfield units. And generally speaking, the non-contrast scan, there'll be more than about 20 Hounsfield units to begin with. I'm also obviously looking at size. I'm looking at location and relationship to the collecting system. And of course, I'm also looking around the kidney, so the contralateral kidney and any signs of metastases.
Okay. Hounsfield units enhancement is 35 and the lesion itself is quite suspicious for possible RCC. You mentioned about you will look for its proximity to the collecting system, etc. What is the importance of that?
There's two reasons. Not in this case, but generally sometimes these renal lesions could be a upper tract urothelial cancer. So it might be important to assess the collecting system in more detail. But more importantly, in this case, it's for surgical planning. So that's going to affect your nephrometry scores and ultimately your risk of complications. And you'll do slightly different things, practically speaking, during an operation, partial nephrectomy.
What is the nephrometry score?
There are two widely used ones, the Padua score and the renal score. The one I'm most familiar with is the renal score. It looks at a number of anatomical areas. So things such as tumor size, tumor location in relation to polar lines, as I say, in relation to the collecting system, whether it's very exo or endophytic, whether it's anterior or posterior, and its relationship to the renal hilum. And based on that score, it will give a risk, low, intermediate, or high risk, and will give you a rough percentage in terms of potential complications. And it's also quite useful for audit purposes.
Okay. How it differs from the Padua score?
I believe the Padua score doesn't include the hilum involvement. I can't recall the other differences.
Okay. So let us assume that this patient's renal score shows it's a low risk lesion as far as the renal score is concerned. Otherwise, the lesion is suspicious for RCC because of the enhancement of 35 Hounsfield unit compared to the non-contrast phase. So what's your next stage of treatment?
So I, of course, discussed this gentleman in the MDT. I'd see him back in clinic with a CNS, and I'd explain what the findings are. So I'd explain that generally speaking, renal masses can be benign or malignant. And I'd explain that the size is 2.5 centimeters on the CT as well, presumably. So I'd explain that the smaller the size, the lower the chance of malignancy. However, there is always that risk. And the options, broadly speaking, will be to either survey things, active surveillance, focal therapy, and surgery in the form of partial nephrectomy would be the gold standard in this situation. Radical nephrectomy is also an option, but it certainly wouldn't be the first option. I'll explain the pros and cons of each of these.
Okay, as you can see, he's quite young, fit patient, and CT-wise, it's a definite RCC. Whether these features help you to make a decision?
Yeah, so I would still discuss all options, but I would err towards active treatment in a young, fit gentleman like this with suspicious features. So I would discuss the option of partial nephrectomy. and I'd explain the approach as local resources would allow, and I'd explain what the risks and benefits of it are.
You mentioned about active surveillance. Is there any specific group of patients or renal lesion where you prefer active surveillance?
Yeah, so I mean, generally speaking, we know from the evidence that the rate of metastases in these patients with small renal masses is relatively low. The Jewett paper looked at patients and found that the chance is about 1.1%, but it does start to increase as you approach 3 centimeters. In the elderly population, we know that the survival, there's no real survival advantage to treating these actively. The Lane et al. Paper looked at patients over 75 and showed there was no real difference here. So certainly for elderly patients with small renal masses, it's a very good option. The other potential option as per EAU guidelines would be to biopsy these to sort of risk stratify them in terms of histology prior to active surveillance, and for low risk lesions, it's also an option.
Okay, so if you're planning partial nephrectomy, how are you going to take this patient further?
So we discussed in the MDT with the nephrectomists. Sometimes a arterial phase CT is useful to assess the vascular anatomy. In our region, we tend to offer a robotic partial nephrectomies in our tertiary center. So I counsel them about what that involves. It's normally a 1 or 2 night stay in hospital afterwards. I'd explain that it's a minimally invasive approach to the kidney with a small open incision to remove the actual tumor. And I'd explain the risks, broadly speaking. So I divide them into early, intermediate, early, and late. And the immediate risks would be visceral injury or severe bleeding or need for conversion into radical nephrectomy or open nephrectomy. The early risks would be bleeding requiring transfusion embolization or potentially even nephrectomy, infection of the wounds or deeper structures. And then the later complications would be urinary leak or recurrence or metastatic disease and further treatment.
What is the advantage of a robotic approach?
It is because it's a minimally invasive approach, the recovery time is much shorter, and oncologically it's not inferior.
Okay, so how will you explain this further? Say, for example, you can use the Bowes information leaflet, you can involve the Macmillan nurse. You said about MDT, that's good. So those are the 2 components which you can add to this. Take me through your approach on the day of the surgery. Patient has come, you have consented already, and patient is sitting in front of you.
Yeah, so the patient's been consented and marked as well. So once they've been appropriately counselled, then in theatre I do my team brief, and then we proceed once we're ready for the patient, and we do our checklist. They normally have trust-driven antibiotic prophylaxis prior to the procedure and induction. They'd be in the lateral position. I think this is on the left side, left lateral position. And then we would insert our robotic ports and as well as our laparoscopic assistant ports. And then the broad steps of the procedure, it can be done either retro or transperitoneal, but transperitoneally, you'd medialize the colon, expose the renal hilar vessels, and presuming you're doing a clamped partial nephrectomy, once you've opened your rotas and marked out the renal tumor, the mark of excision, you then go and use a bulldog to clamp off the renal artery, start your warm ischemic time timer, and then you'd enucleate, normally or nuclear resect the tumor, and then close the defect using bolsters, and then, close Gerota's fascia, put a drain in, and close. Take the tumor out and close.
You said antibiotic. What antibiotic? Why antibiotic?
So in our protocol, we would use gram-positive cover, so chimoxiclav for the skin commensals, and urinary cover in the form of gentamicin.
Say, for example, if you are doing open nephrectomy for organ confined RCC, how will you classify this surgery? Open radical nephrectomy for T2 organ confined RCC. Is it like a clean or clean contaminated or dirty?
This would be a clean procedure because we're not we're not opening bowel, we're not opening anything non-sterile.
Okay, so in which way it differs from the robotic approach for this small renal tumors?
We're potentially opening the collecting system, so there could be urinary leak from that point of view.
In case if you're opening the collecting system, how are you going to close it, and take me through the exit strategy once you resect the suspicious lesion?
Yeah, so some people will prophylactically stent, but often we won't. You'd formally close the collecting system using an absorbable suture, and then the remainder of the renal parenchyma will then be closed in layers, 1 or 2 layers, using hemoclip to sort of bolster it. If there's a very large defect, you may insert hemostatic material in between to bolster things. And then, yeah, once the tumor is out, so generally speaking, once the tumor is out of the kidney, we'd unclamp to see if there's any bleeders, which could then be oversewn. The clamp would be off. We'd remove the tumor from the body and leave a drain in, as I say, and then close.
Okay. You said 1 or 2 nights stay. In general, these tumors could be in some centers can be done as a day procedure if the patient is listed first in the list, or maybe 1 night stay. 2 night stay is slightly overkill, but again, it depends upon the individual hospital practice. Okay, this man has got an uneventful post-op period. He recovered and went home. His histology came as 2.6 centimeter, clear cell renal cell carcinoma. Surgical margins were positive, and otherwise you haven't done any lymph nodes or anything. So how are you going to treat him?
What grade did you say it is?
It's grade 2.
It's grade 2. Okay. So if you look at the Liebovic scoring system, this would probably be in the lower risk category. I'd need to calculate it formally. The positive margin status is not really included in that, but it's something that I would keep in mind. Generally speaking, he could be given low risk follow-up, so he'd have sequential CTs as per that protocol. But I'd probably increase the frequency of that given his positive margin. So I may do an early CT in the first instance.
Explain the components of Liebovic scoring system.
So it describes tumor size, T stage, grade, nodal status, the presence of tumor necrosis. Those are the ones I can remember.
Okay, how will you explain this diagnosis to the patient? What is the further plan?
So I'd explain that there was a cancer, so we were right to treat it actively. I'd explain that although we've removed it, there is a what we call a positive margin. So what I'd explain is that we aim to, in order to confirm we've removed the entire tumor, have a margin of healthy tissue around the tumor, and that confirms we removed the whole thing. And in one small area of his specimen, the tumor was extending right to the edge of it. That's what we call a positive margin. So I'd say that does increase the chance of him having recurrence in the kidney, but it's not a huge increase. The evidence is that if there were negative margins, I think the local recurrence rate is under 5%. It's about 16% for positive margin status. So it's something that we don't need to jump in to do anything for now, as we'd likely overtreat it if we take the rest of the kidney out. But we probably keep a closer eye on things. And of course, if we see anything abnormal there that we're worried about, we'd reinvestigate things and potentially offer further treatment.
That's very good answer. The main thing is the positive margin still says that you got the positive margin on the specimen side. There is no assurance that there is a definite tumor present in the patient side. That's number one. The number two is, even if there is some cells or a layer on the patient side positive, the chances of it really getting into a definite recurrence is very less. That's why you have only 16%. While if that residual tissue on the patient side supposed to give a recurrence, the answer should be 100%, isn't it? So the
Yeah.
concept of positive margin is slowly changing. How will you say that the margins are negative? Is there any measurement available?
I think just one cell is enough to call it a negative margin.
Yeah, theoretically one cell, but if you take histology wise, even a 2 millimeter healthy margin is more than enough to say that there is a negative margin. Okay.
Okay.
Yeah. While surgery, you may wish to preserve maybe like 5 millimeter, or if permits like 10 millimeter margin, maybe 5 millimeter margin during the surgery is more than enough. Good. We have finished one scenario. Do you have any questions in this scenario before we go to the next one?
Yeah, just the only thing I was going to mention was genetic testing. I know, did you say he was 45, 46?
45, yeah.
Is that something that I should talk about, or is that something we don't
Yeah.
tend to do?
Yeah, it depends upon the institute. Usually less than 40 genetic testing is important, but 40 to 50 also is not a bad one. So nothing wrong in referring the patient to the genetic testing.
Okay.
You need to bring the Macmillan test on MDT again when the patient histology is discussed. You haven't brought the Macmillan at all in the whole presentation. So let's keep that in the back of your mind.
Okay. Okay.
Okay, and there is a lot of studies on the day care robotic partial nephrectomies, even though that's not in the preamble of most of the surgeons, but those are all the topics which could be discussed. Okay.
Okay. Okay.
Good.